Got any questions for me? JM is the key. This is John Mendoza, and welcome to my vlog. Tracheostomy refers to the creation of communication between the trachea and the overlying skin. This may be done either by open or percutaneous technique. To compare tracheostomy from tracheotomy, tracheostomy is the formation of a permanent opening that remains open after the tube has been removed, while tracheotomy is the formation of an opening that will spontaneously close when the tracheotomy tube has been decannulated. Indications: tracheostomy is done for airway obstruction, respiratory support such as assisted ventilation, pulmonary hygiene, elimination of dead space, and treatment of obstructive sleep apnea. There are no absolute contraindications for tracheostomy. However, a strong relative contraindication to discrete surgical access to the airway is the anticipation that the blockage is a laryngeal carcinoma. Important surface landmarks for tracheostomy include the thyroid or laryngeal prominence, cricothyroid membrane, and the cricoid cartilage. Materials needed include cotton with povidone iodine, local anesthesia, scalpel, forceps, needle holder, scissors, hemostat sponges, suture set, tracheostomy tube of appropriate size, suction apparatus, electrocautery, and retractors. Place the patient in a supine position with the neck extended by a pillow or bag placed under the shoulders. This is to deliver the trachea out of the thorax and to give adequate access to the cervical trachea. Identify the thyroid prominence. Moving inferiorly, the finger slips into the depression of the cricothyroid membrane, followed by the solid prominence of cricoid cartilage. The skin incision is typically placed 1 finger breadth below the cricoid prominence or 2 finger breadths above the sternal notch. The tracheostomy is created below the first tracheal ring to avoid subglottic stenosis as a result of scarring. Prepare the site by sterilizing the skin of the anterior neck and chest and then drape the neck. Infiltrate the skin with a local anesthetic such as lidocaine. Make a horizontal incision along the marked area through the dermis. The subcutaneous tissue is then dissected by an electrocautery to aid in exposure and to prevent later fat necrosis. Dissect towards the trachea by parting the tissues with scissors, remaining strictly in the midline by a vertical plane to avoid injury to the inferior thyroid veins. Identify the midline cervical fascial plane between the sternohyoid muscles and then divide this by spreading it. Repeat this maneuver to separate the sternohyoid muscles and retract them laterally. Retract the thyroid isthmus superiorly with retractors to expose the trachea. Aspirating air with a needle attached to the syringe will confirm the location of the trachea if there are doubts or concerns for it being confused with a carotid artery. Ensure that the surgical field is dried completely before proceeding, as it is difficult to achieve hemostasis once the tracheostomy tube has been inserted. In an awake patient, inject lidocaine into the tracheal lumen prior to incision to reduce cuffing. An anterior base flap is created, raised from the anterior wall to the 3rd and 4th tracheal rings. A silk traction suture is passed through this flap and loosely secured to the skin. This facilitates reinsertion of the tracheostomy tube in case of accidental decannulation and avoids the tube passing into a false track anterior to the trachea. Assess the size of the trachea and select the largest cuff tracheostomy tube that comfortably fits the tracheal lumen. Inject air into the inflatable cuff of the tube to test its integrity. Insert the tracheostomy tube into the tracheostomy under direct vision while applying traction to the silk traction suture attached to the tracheal flap. Then, inflate the cuff and attach the anesthetic tubing. The tube may also be sutured to the skin. Secure the flanges of the tracheostomy tube and pass them around the neck. Tie them with a neck flex. Complications can be divided into intraprocedural, early, and late. Intraprocedural complications include airway fire, bleeding, pneumothorax, and pneumomediastinum. Early complications are those less than 7 days post-operatively and include infection, tube obstruction, and accidental decannulation. While late complications include tracheal stenosis, tracheoinnominate fistula, tracheoesophageal fistula, and tracheocutaneous fistula. Follow me for more videos on JM is the Key. Adios!